Welcome to this BTOG podcast. My name is Newsom-Davis and I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm Vice-Chair of the BTOG Steering Committee. I hope by now that you know that this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and we tackle the most important questions that we all face in the diagnosis and the treatment of thoracic cancers. It's important to say that the sponsors of BTOG do not in any way have any input to the planning, content, or delivery of anything that we discuss.
Welcome to another episode of our BTOG podcast, BTOG Does. My name is still Tom Newsom-Davis. I'm a medical oncologist at Chelsea and Westminster Hospital and Vice Chair of the BTOG Steering Committee. As you may know, as an avid regular listener, we have been focusing recently on rare mutations in lung cancer. And I think it's a really important thing to do because we may not see these patients very much, but when we do, we must make sure we know what's going on. We must make sure we're acquainted with the best treatments to best serve them. So this week, we're going to focus on RET. And I'm delighted to be joined by my colleague from up the road in Chelsea, Nadza Tokaca, who is a medical oncologist at the Royal Marsden Hospital. Nadza, welcome to our podcast.
Hello, Tom. Thank you for having me.
It's my great pleasure. Thank you for giving your Tuesday evening to join me on the end of a Teams call. So RET fusions is what we're going to focus on. I guess my first question, as always, I start off with the basics, is what is RET? And people will know that RET is one of the fusions we see. Tell me about RET and tell me about how it might relate to other fusions in terms of how common it is, that kind of thing.
Okay, so RET, it stands for rearranged during transfection. So very intuitive name there, but we'll continue with RET from here. It is a tyrosine kinase receptor, so we're familiar with those. And like other TKRs, it can be pro-oncogenic when its activation is abnormally altered. And as we know with other TKIs, abnormal activation can be a result of changes in the gene sequence, and that can happen through either mutations, so changes in a single point in the gene sequence, or due to rearrangements, which are sort of juxtapositions within the gene sequences, or as we most commonly see in our non-small cell lung cancer patients, it can be due to fusions of the genes. So RET fusions are the type of abnormal RET variant that we see most commonly in non-small cell lung cancer.
I'm going to jump in there and annoy you. You made a really interesting point about there being more than one abnormality. You can just get RET mutations. If one of our colleagues is looking at their NGS report, there isn't a fusion, but there's a RET mutation. That's a different beast to what we're talking about generally here. Is that correct?
That's exactly right. So you may observe RET mutations in other malignancies that may be pathogenic, or there may be, currently I'm not aware of any that are targetable. However, in non-small cell lung cancer, they're likely to be of uncertain significance, and they're certainly not currently actionable in a kind of therapeutic sense.
Grand. Sorry, I cut you off in your prime just before that.
That's absolutely fine. Do stop me if I start to go on too much. But I think I was just about to say that these RET fusions that we see in non-small cell lung cancer, we only see in about 1 to 2% of advanced non-small cell lung cancer patients. So they are comparatively rare to some of the other variants that we see.
So a bit less common than ALK?
A bit less common than ALK. We'll probably see ALK in up to about 5%.
So maybe similar to ROS1, perhaps?
Probably similar, somewhere along with ROS1,
And who gets this? Are we talking about our classic non-smoking patient population? If so, do we have any guides about age, gender, histological subtype, those kind of things, to allow people to keep an eye out for a possible RET patient?
Yes, RET fusions are more commonly seen in younger patients, generally those under the age of around 60. They are predominantly seen in patients who have a very light smoking history or who have never smoked, and they're most commonly seen in patients with adenocarcinoma, histological subtype. And this is all kind of common to other oncogenic drivers that we see in non-small cell lung cancer. They tend to present at more advanced disease stage, and around half of the patients will develop brain metastases over their lifetime. So brain metastases, their presentation also quite common.
And do we see, like we do in some of the other rarer subtypes, like the ROS ones, do we see that venous thromboembolism increased risk, or is that not something we see in RET?
Do you know what, in RET, I think I have seen it, but I'm not aware of any data to tell us actually of the frequency. I suppose it's part of that rarity of the fusion.
Yeah. So our colleagues need to be keeping an eye out for this non-smoking, younger adenocarcinoma patient population, which we're now familiar with, that may be harboring a mutation. They're going to be getting their NGS back. How do we? What's the best way of diagnosing RET? If you had your best way, how would you do this?
Well, there are several different molecular testing techniques that are available out there to detect RET alterations. We know of things like immunohistochemistry, RT-PCR, FISH, which are generally widely available, familiar to most our laboratories, but they don't have quite the sensitivity that we need to detect RET fusions. What is currently internationally recommended in guidelines such as ESMO guidelines are essentially RNA-based NGS techniques as the first choice for detection of RET fusions. And that's because of their superiority in terms of sensitivity and specificity over some of the other techniques that are available.
I think that's a really important thing just to say, which is for those perhaps a little bit less experienced with molecular results, to remember that when your lab gives back your results, certainly the results I get from the Marsden Molecular Hub, which do ours down at Chelsea, we get a DNA and a separate RNA analysis. Always make sure you've seen both, because if you've only seen a DNA analysis, you have not seen a proper fusion panel, and you must look at that. Really important.
That's exactly right.
RNA NGS is your go-to, and that would be seen as the gold standard, correct?
That's exactly right. So we always do both, as you say, DNA and RNA NGS on our Royal Marsden panel of around 200 tissue genes that we test for. The thing to say is that the reason for this low specificity or sensitivity with the DNA is that you can't quite discriminate between what's expressed and unexpressed with the DNA in terms of genes. And also if you've got large intronic regions, so these regions that do not encode a protein, or you have lots of repetitive sequences of DNA, then that does impact DNA performance. Whereas with your RNA sequencing, you're only analyzing the transcriptome, so the stuff that's actually encoding the protein, and that has better ability to detect your RET fusion partner. And obviously RET fusion, a RET gene can have a number of different fusion partners, and that also may have some implication in terms of prognosis and predictive value in terms of sort of your future treatments.
Tell me a bit about that. The commonest being KIF5B. I've always called it KIF5B. I don't know if that's the really right one. That's the one I've tended to see the most common. There are some others. If our colleagues are getting their NGS result back and they're telling them different partners, does that make a practical difference, or are we going to be treating them the same way, and this is more of academic interest?
Yes, that's right. The KIF5B RET fusions account for the majority of the fusions we see. So around 70 to 90% of cases will be KIF5B RETs, and then followed by CCDC6 RET fusions and COA4 RET. That's the kind of the other common ones that we see. I mean, they will all be targetable, and they should all be treated with RET targeting therapies. And work around the clinical implications of these specific gene fusion partners isn't fully defined, but there is some data to suggest that efficacy of RET inhibitors may vary depending on the RET fusion partner. For example, there is some data from the ARROW trial, which we'll talk a bit more about, I suspect, in a bit, which is the trial of Fonsetinib in advanced non-small cell lung cancer. So that indicates that patients with the CCDC6 RET-driven disease may have slightly better prognosis compared to the others.
So if our colleagues don't happen to have access to a reliable RNA NGS panel, and unfortunately it remains the case that not everyone in the UK does, are there any other tissue-based assays which are second best but will do, or really should people be absolutely holding out for RNA NGS and somehow finding a provider elsewhere that can do that?
Yeah, I mean, obviously RNA, as you say, NGS will be the gold standards. IHC is widely available and it's most convenient, but it does have poor sensitivity and as well as high false positive rates, so you can't rely on it fully. The FISH is probably your next go-to as well, so you could either confirm your IHC finding with FISH.
Okay. ctDNA, very much the exciting thing going on at the moment. We of course have a national ctDNA pilot going on, which you and I are part of. Very exciting. How good is ctDNA at picking up RET fusions, and is there a difference in the different panels? People might be familiar with Guardant, they might be familiar with Foundation, they may be familiar with other platforms as well. There are more than one. What's your take on that?
I mean, as we know, there are huge advantages to ctDNA testing. It's a simple blood draw, can be done in clinic. It'll spare the patient invasive procedures and can be repeated easily. It can also sort of reflect some of the heterogeneity that we may see across the different metastatic sites, which will all shed the ctDNA into the bloodstream. I suppose the main concern about ctDNA that we're aware of is its lower sensitivity. Yeah. So you may not pick up much of it in patients who have limited disease in terms of disease burden, or may have predominantly sort of intrathoracic disease, so not many extrathoracic disease sites. So if you have a negative ctDNA, you have to revert back to tissue.
But if it's positive, you're happy.
Well, but if it's positive, and that's the big change that's occurred fairly recently, is that now the NHS commissioning allows us to commence these targeted treatments based on ctDNA findings of a confirmed oncogenic driver without the need for tissue confirmation, provided we have a correct radiological context of metastatic non-small cell lung cancer, which is where our pilot comes in. And hopefully that will confirm that it's a feasible and cost-effective way to introduce ctDNA NGS into clinic. In terms of your question regarding the different panels, I mean, they're all much of a muchness. It's all about the reporting, I think, when it comes to these different panels. So the key is getting a report that makes sense and that's reasonable, that has the information in it that you need. Some of them, for example, will report things like copy numbers and variant allele fraction, which others don't, and there's all useful information. So the ones that give you the most clear, optimal information are the best to use.
I think that's one slight disadvantage, I think, of ctDNA, which is you haven't got someone to speak to. And I would strongly recommend to colleagues, they would have heard me banging about this before, which is when you get your tissue molecular result back, if you're not sure, find a friend in the lab and email them. And you and my colleague Suzanne McMahon, who's in your lab, is fabulous at answering my annoying emails. But if you don't understand, just email and ask, because you can learn. I learned so much from my molecular colleagues.
Oh, absolutely. It's all about getting that expert advice and interpretation from people who know how the assays work. And we're very lucky that we have access to a genomic tumor board where we essentially discuss all of our ctDNA and NGS results. And we do come across many that are very challenging to interpret.
Yeah. So you touched a little bit upon the fact that patients with RET, unfortunately, more likely to have brain metastases. So would you be doing a baseline MRI for anyone you found out had a RET fusion?
Yes, absolutely. They're highly likely to have brain metastasis diagnosis, but even for those that don't, in our centre we are performing regular MRI brain surveillance, usually about 6 monthly, during treatment in patients without brain metastases.
And I think that's good practice. I mean, that very much fits in with what is often done in ALK. There's a lot of similarities, and I do agree with that, and we do it. I appreciate that not everyone has access to MRI readily, although if you're doing it 6 monthly, it is usually feasible. And I appreciate there is a bit of a debate about would you want to know and effect on driving and driving licenses, but because you can do so much if there are brain metastases, I do think it's an important thing to consider. Any other particular diagnostics in terms of imaging, or apart from the MRI and making sure that we've done our proper NGS, is that our lot?
I think that's generally our lot. I mean, all patients should have full staging investigation as standard, your CT or PET. Obviously, all the patients with early non-small cell lung cancer with a RET fusion should be considered for the standard radical treatment approaches with surgery or radiotherapy. And there are some research in that area in terms of trying to bring RET inhibitors into the adjuvant and neoadjuvant setting. So important to be aware of the molecular profile of those patients with early non-small cell lung cancer as well.
That's a really good point, and I think we should remind people that, of course, at the moment we are doing it in the advanced setting, but there are trials going on, as you say, Libretto being one of the Libretto studies being in the adjuvant setting. So see whether that is available regionally. We've just opened it at Chelsea. We're about to open it at Chelsea, actually.
Oh,
Okay, so we're going to move on to the exciting stuff, which is what gets oncologists really excited, and probably all of our respiratory friends falling asleep. But what is the first line treatment if someone has picked up a RET fusion? Because that has changed in terms of what's available through NICE. People may know that there are predominantly two main drugs which are licensed, which is selpercatinib and pralsetinib. Let's focus on selpercatinib first. That's the Libretto 001 study, is the main detail. Tell us about that, and perhaps compare it to the Arrow trial, which is the pralsetinib study. What's your take on those?
So as you say, selpercatinib is one of our currently licensed treatments, and it's available in the NHS on the Cancer Drugs Fund.
Right.
It's a highly selective and potent RET inhibitor and has strong CNS activity as well, and it's been specifically designed to target activated RET signaling. It's a bit of a historical background. Prior to selpercatinib and pralsetinib coming along, there have been a number of non-selective RET inhibitors, so multi-kinase inhibitors that were tested in preclinical setting did show some inhibitory activity on RET, but unfortunately that never translated into clinical benefit. So really very exciting when selpercatinib and pralsetinib came along, and early data on the benefit of selpercatinib came from the Libretto 001 trial. That published its preliminary data in 2020. That was a single-arm phase 2 clinical trial, and that looked at selpercatinib both pre-treated and treatment-naive patients, and showed response rates around 60% in your pre-treated patients, and about almost 85% in patients who were treatment-naive with selpercatinib. Most excitingly and importantly, the intracranial response rates were in the order of almost 90% with patients with brain metastases. And then based on this data, that was taken forward into the phase 3 trial of selpercatinib called Libretto 431, and that started enrolling in about early 2020. And this is a proper multi-center randomized comparative phase 3 trial, which is comparing selpercatinib with platinum-based chemotherapy with or without pembrolizumab in treatment-naive patients. And only a couple of weeks ago, we had a presentation at ESMO of its early PFS data. So this was from the pre-planned interim analysis, which showed near doubling of PFS in favor of selpercatinib with a hazard ratio of 0.46, which is really quite exciting.
And just to remind the audience that was in ESMO 23, and this podcast is going out after our BTOG ESMO update. But if you wanted to see a bit more about the Libretto data and see some of the slides, I'm sure it's going to be included in that update. So that Libretto 431, that selpercatinib versus chemo stroke immuno was in the presidential session, and was, all sorts of excitement going on when that came out. So interestingly enough, what you in fact have said is that selpercatinib was licensed and NICE approved on the basis of a phase 1, phase 2 study.
That's absolutely right. Yes, it is, a NICE approved within the certain funding criteria and only currently available within the CDF. Hopefully this phase 3 data will strengthen its position further and make it more routinely commissioned.
And I think that's a really important just side thing to pick out, which is in rare tumours, it's very difficult to run big studies. And I think it's to the credit of the company behind selpercatinib that they went on and did this big Libretto 431 study. But there are downsides to that. And there's this fabulous discussion in ESMO by a gentleman called Benjamin Bessin, who's from Institut Gustave Roussy in France, kind of railing actually against the fact that why have we had to undertake a large phase 3 study to show what we knew already, which is it's a really good drug, which have cost huge amounts of money and will have meant that some patients didn't get selpercatinib and got chemo. And is that the right thing to do? And I think he makes a very good point, because I think selpercatinib is a really good example of a drug that we knew was really effective based on phase 1, phase 2, and got through NICE. You rightly say, with some conditions attached. And we should be championing this approach where you don't have to wait 5 years for 300 people to go through a study. We can do it in select drugs on smaller numbers. So it's clearly a very effective drug. Is pralsetinib as effective? That was in the ARROW study. That was their phase 1, phase 2 study.
That's right. I mean, pralsetinib was, went through very similar testing in phase 1, 2, and, again, good overall responses were seen. Around 60% of patients previously treated with platinum-based chemo did have a response, and around 70% of treatment-naive patients. So again, pretty impressive numbers. Don't quite have the same data on the intracranial responses as we did from Libretto, but that is currently also being evaluated in a phase 3 trial, and data on that is still outstanding. I believe that's only just that's the Accelerate, and I believe that's only just completed recruitment.
So do you think there's, can you choose between the two drugs? I mean, admittedly, the only one available, I believe, on NICE or 3 NICE is selpercatinib. But if you had a magic wand, both available, is there anything in it, or is it Pepsi versus Cola? They're all the same thing.
It's difficult to tell at the moment. I mean, pralsetinib is certainly approved in the US and EU, but not funded in England and Wales, and it's to do with cost effectiveness rather than necessarily lack of inferior efficacy compared to selpercatinib. But as I say, selpercatinib at the moment, it's this brain data that I think at the moment will make me go for that first.
And so clearly effective. You talked about the very high response rate, the very high intracranial response rate. Good durations of activity, the median progression-free survival, the progression-free survival hazard ratio, I think you said in the Libretto 431, selper versus chemo stroke IO was 0.47, which is very impressive. What about side effects? Are these easy drugs? Are these difficult drugs? Are there any particular toxicities we should be keeping our eye open for?
Yeah, so the adverse events for both of the drugs are mainly due to their off-target effects on the VEGF signaling pathway. So it's things like hypertension, edema, diarrhea. You also get a bit of nausea, abdominal pain, headaches. They will cause low blood counts, particularly pralsetinib, and liver enzyme elevations like transaminitis. But these are all things that we can generally manage in clinic. So certainly better tolerated than the chemotherapy.
And the hypertension, certainly in the patients I've had on these agents, is something to watch. It's reasonably easy to manage, although we've all slightly forgotten how to manage hypertension, which is a bit embarrassing. But yeah, I've seen that, and I've certainly seen elevation of liver enzymes, which did sometimes require a dose reduction. But as you say, it's very similar to that we're seeing with lots of our targeted agents. So that's, I found them more manageable. So, and as you mentioned, selpercatinib in England, Wales is available first line, and we wait to see whether other agents join that as well.
It's actually currently available within the Cancer Drug Fund for both previously treated and treatment-naive RET fusion-positive patients. So if you've got a patient who had chemo or IO before and is now progressing, and you've discovered a RET fusion, you can access selpercatinib.
You've taken the word out of my mouth. It's a really important point, which is sometimes we don't spot these in time, and you find them with hindsight, or you get the NGS back after you've started. So if you've got a patient who's been on chemo, we still have access second line. They must get these agents because they are very effective. Absolutely. Let's say you've had someone who's been on their selpercatinib, they've had a great response, but unfortunately a year in, there is progression. But actually, it's just intracranial progression, and there's ongoing extracranial control. Would you switch agents, or would you be speaking to your friendly neuro-oncology team to get their expensive machines out?
Yeah, it's a very good question. What we tend to do is that we do tend to go and talk to our friendly neuro-oncology colleagues and try and maximize the duration of that first-line treatment. Unfortunately, there isn't a lot of good data behind that, but anecdotally at least, it does seem to prolong the value of that first-line targeted treatment, and we just like to keep our patients on a targeted therapy for as long as possible in the absence of good second-line targeted options.
And similarly, if you had isolated extracranial progression, solitary liver metastasis or a solitary bone metastasis, would you be continuing your TKI and persuading our clinical oncology colleagues to irradiate that one area?
Again, that's probably one of the trickier situations. We currently don't have commissioning of funding for stereotactic body radiotherapy in that setting. There was an excellent trial called HOLT trial that was open here, but has now completed recruitment, and that was recruiting patients with oncogene-driven non-small cell lung cancer with oligometastatic progression, so progression at very few sites of extracranial disease, and then those patients are randomized to either just continue their targeted treatment or to have stereotactic body radiotherapy to those oligoprogressive sites and continue their targeted treatment. And we are looking forward to that data coming through. But at the moment, generally speaking, I suppose it's a sort of clinical decision based on the individual patient as to whether you feel that switching to second-line therapy, such as chemotherapy, which is currently standard, or would be preferred to continuing.
And we look forward to that HOLT trial, which is run by friend of BTOG, Fiona MacDonald. Hopefully that will report soon and may influence some of the commissioning rules that we are under. So let's say, in fact, there's multifocal progression, or there are no targeted radiotherapy options. After selpercatinib in the outside of clinical trials, you mentioned chemotherapy. Would pemetrexed carboplatin be your go-to agent? And would you be adding an immunotherapy? Do you feel immunotherapy adds anything to these non-smoking mutation-driven cancers, or are we just adding an extra expensive drug that we don't need?
Yeah, so we know that, or we have some data at least to show that RET altered lung cancer seem to be particularly sensitive to pemetrexed-based chemo regimes. So certainly carboplatin pemetrexed would be my chemo choice in the relapse setting. There was some good retrospective data that showed that pemetrexed-based chemo was better or preferred over non-pemetrexed-based regimens in both first and second line setting when compared to immune checkpoint inhibitors or multikinase inhibitors. Immunotherapy, unfortunately, there's good and increasing data to show that it has limited efficacy in all oncogene-driven advanced non-small cell lung cancers, including RET fusion-positive cancers. And in fact, several real-world studies with immune checkpoint inhibitors have indicated lack of benefit. And in fact, patients who received non-immune checkpoint inhibitor therapy were at decreased risk of disease progression compared to those who received ICRs. So definitely wouldn't be my go-to immediately. You'd have to think about that fairly carefully as to what benefit.
I couldn't agree more. I think it's a really important message. There is very little evidence that they're beneficial. They do increase the risk of subsequent issues with things like pneumonitis. We've seen this with other mutations. We see it with ALK. We see it with EGFR exon 20 insertion. And we've had some data for other mutation-driven cancers confirming this to be the case, for example, Keynote 789. So I agree with you. I don't think we should be using immunotherapy in these patients, which is difficult because given the young age and the patient demographic, they're the guys who tend to know about immunotherapy and want to know where their immunotherapy is. But I think we have to be clear that this is not something that we should be throwing around unless there's particular unusual reasons to do so.
That's right. I mean, it can be difficult conversations in clinic.
Yeah.
We're doing PD-L1 testing on these patients. They may have high PD-L1 expression, but there is no evidence that even those patients
absolutely
benefit.
No, I absolutely agree with you. What in terms of prognosis, so we've talked about that these patients are doing well. The median progression-free survival in Libretto 431 was over 2 years, which is fabulous. Are there any other things we can guide our prognostication? We know, for example, in ALK, that if you also have a TP53 mutation or an RB1 mutation, similarly actually in EGFR, that prognosis is unfortunately less good than just an ALK or just an EGFR. Do we have the same thing in RET, or is this still an evidence-free zone?
Yeah, I think there's not a lot of evidence behind it. We talked a little bit about fusion partners and that might have some prognostic implications. But certainly we know that co-occurring variants like TP53, RB1, STK11, etc., could carry worse prognosis because partly they're also they tend to be less chemo and radiosensitive. So whatever future treatments you might wish to employ, they may be less effective.
And the new things in RET. So you mentioned Libretto 431. So I'm just going to briefly revisit that. So this was the phase 3 confirmation of first-line cell pacatinib compared to chemo plus or minus immuno. Big study, very impressive. They managed to recruit to it. I think everyone thought that was pretty good. We've talked about the median progression-free survival. We talked about the progression-free survival hazard ratio 0.7, which is pretty impressive. No new signals in terms of toxicity, but some interesting data about brain activity, neuroprotection. I guess that fits in with what you said earlier about how effective these drugs are. What was your take on the Libretto data, in particular the brain bit?
I mean, we have to remember that this is all results of a interim efficacy analysis, so it's early data, and as always we've got to wait for mature data, and we've got to wait for overall survival data, but it would be difficult to imagine that this magnitude of benefit that we see with PFS wouldn't translate into.
Yes, I would fall off my seat personally, but as you say, we must wait like good clinicians for the data.
But certainly the PFS data for progression in the central nervous system was also very impressive. I think the hazard ratio for the core-specific hazard ratio for progression in the CNS was something like 0.28. So again,
it's extraordinary, isn't it? Extraordinary number.
Yeah.
And so just for those of you who aren't familiar with what that means, there's more than 80% reduction in the chances of progression, which is remarkable and fits in interestingly with the phase 1 data. I was looking through, I was cheating actually before you came online. I had a quick look at one of the tweets I sent from ESMO. And I was looking whether there was a difference in PFS between the different fusion partners, and there didn't seem to be so far. So we will see whether the phase 3 data bears that out or not. And I couldn't see any other particular subgroup that did or didn't benefit. And interestingly, whether you had brain metastases or not, you did equally well. Different genders equally well. No difference according to geographical or racial heritage. Kind of across the board, it's a better treatment, basically.
Absolutely.
Yeah. So that's Libretto 431. You mentioned Accelerate, which is the pralsetinib phase 3, which we think is now finished recruiting, and we look forward to data. That might be next year. Who knows?
That's correct. I believe they're only just still open for recruitment, but I think planned recruitment was end of October. So I think they're nearly there. And yes, it'll probably take a year or so to get that data through.
Yeah.
So eagerly awaiting that.
And what's really new in data? So let's say we have someone who's been through a first-line RET inhibitor. They have been through their second-line chemo. They have progressed. Do we have novel RET agents coming through? Or is it also early? They're just a combination of letters and numbers, and we don't know quite what the drugs are yet and how well they work.
So I suppose there are a couple of strategies for overcoming resistance to RET inhibitors. One is potentially targeting MET as one of the resistance mechanisms. Yep. So we see that commonly with other oncogenic drivers. It's a pathway that's commonly altered under TKI pressure. And we see it in about almost 15% of patients from some of the relatively small data cohorts from tissue and blood of RET-treated patients. So there are, again, some very small numbers, but patients who've been treated with MET targeting drugs such as crizotinib or cabozantinib with selpercatinib, who also have increased MET expression. And there has been some clinical benefit reported, including partial responses.
And does that mean that, sorry to interrupt you, but does that mean with your first line or post chemo patients you're rebiopsying, or and should our colleagues be considering that, or is that still a bit niche?
Probably not as common in RET as it is with other oncogenic drivers, where we do have established second line targeted agents. However, absolutely always worth considering a rebiopsy or hopefully in the future a liquid biopsy. Look at these, to look for resistance mechanisms. But there is another strategy, and that's, as you say, sort of novel next generation RET inhibitors, although these are all in relatively early clinical trial development and are at the moment still series of numbers of letters. One of them is LOXO 260. So that's in phase 1/2 at the moment. And that has demonstrated some activity both in treatment resistant and in treatment naive RET driven preclinical cancer models, and some promising early trial data in phase 1/2. And there is another one called TPX0046, and again similarly in very early development at the moment.
And in fact, a shout out to my colleague Marston Forster at UCL, who I think will happen to know is going to be opening a second line or relapsed RET study for people who've already been treated with a RET inhibitor, and that's at UCL hospitals. I believe that's opening sometime in the next month or so, and I'm sure he'd be delighted to help should you have patients. Nadza, that's incredibly helpful. Thank you very much. You've given us beautiful, calm overview of where we are. So I think the take home for the audience is keep an eye out for RET. If you have a young non-smoking patient and you haven't found an EGFR or an ALK, or perhaps the more common ones you might expect, look for RET. Make sure you've got ideally RNA, NGS, but if not, fish will do. There is access through NICE to first-line selpercatinib, and we hope that other agents will join that. If you have already started chemo, then you still have access to these drugs as a second line, again, through NHS funding. Chemo remains an important part of what we do, and drugs can be very effective. Keep an eye out for the brain, do brain scans, and we will both, I think, recommend surveillance brain scans. And in event of progression after RET inhibitors and chemo, well, we hope that we will have new agents coming through in the near future. Nadza, thank you very much for educating me and our audience. Thank you very much to our audience for dialing in. And we will be moving on to more rare mutations in our next couple of podcasts. Nadza, thank you so much.
Thank you very much.